All right. Welcome to the latest Analyzing Healthcare podcast. I'm joined today by the esteemed and highly respected Dr. Andrew von Eschenbach, the former commissioner of the FDA. First question, when were you commissioner? What were the years?
Well, thank you, Roy. It's a pleasure to be joining you. I was commissioner of the FDA from September 2005 to January 2009.
These were important years, which we'll get into in a second. But before we focus on the FDA, just maybe a little bit of background on yourself. How does someone end up being commissioner of the FDA?
Well, I started my career as a urologist. I trained at the University of Pennsylvania in Philadelphia, but I decided that I really wanted to focus on cancer. And so I went to the University of Texas MD Anderson Cancer Center to do a fellowship in urologic oncology, and wound up spending my career there for 26 years. And then in 2002, President Bush appointed me to be the director of the National Cancer Institute. So I kind of went from boots on the ground, if you will, on the front lines, dealing with both cancer research and cancer care, to now find myself at the NIH and at the National Cancer Institute as an AWACS plane, basically overlooking our nation's cancer program. And after 4 years sitting at my desk on a Thursday night, I got a phone call from the White House with a message that said that there was an issue with the FDA and the president wanted to know whether I'd be willing to go over as commissioner. So I found myself as the commissioner of the Food and Drug Administration.
These things just fall into your lap. It's amazing how these positions just open up to some people. The Texas connection there is also duly noted.
Well, MD Anderson always enjoyed the tremendous support from both President Bushes, and I had the fortune and opportunity to work closely with George Herbert Walker Bush, 41, as we did a number of things, including launching the National Dialogue on Cancer. So I had been, as I said, on the front lines, but I had also been increasingly engaged in the larger picture, if you will. I was in line to be the president of the American Cancer Society. So for me, it was a transition from taking care of some patients to try to take care of all patients.
You're the second commissioner that I've spoken to on this podcast and as part of Scale Community. We had the former commissioner of the VA who attended our conference last year, David. So it's interesting to speak to a second commissioner. One question I didn't ask him that I'd love to ask you is, how does it work once you retire from the position? Is it similar to presidents who never really fully leave the role, in the sense that they continue to stay close to new presidents, they form a bond, a community, they discuss with each other, they share in past experiences? So as the FDA has appointed new commissioners over the past 20 years, do you stay in touch with the FDA? Do you work with those commissioners, or is it a clean break?
No, it's interesting question from the point of view that there are some aspects that are, in fact, a clean break. I've never been back to the agency in any way to influence their processes or their decisions. So you step away from that, but you never completely fall out of love with those agencies. And so you remain committed.
It's a special club, isn't it?
Well, it's an experience, and when you've been in that chair and you've had that experience, there are things that you become aware of, that you are knowledgeable about, that the only other person who is someone else who's been in that chair. And so, yes, there is a natural affinity to come together regardless of which president appointed you or which administration you were in. We are, if you will, a band. And there's also this sense of responsibility to the agency. You're there for a fixed period of time. You make your contribution, but at the end of that, your obligation to continue to try to support and enhance those agencies doesn't go away. So there is an ongoing commitment and responsibility, and that's been a part of my post-government career, is to continue to try to contribute to healthcare policy by being involved in think tanks, if you will, like the Bipartisan Policy Center. And I sit on the board of the Reagan-Udall Foundation, which is the 501c3 foundation that Congress put in place to support the mission of the Food and Drug Administration. So we do hang out, and we do, when called upon, try to contribute in our own ways.
It is, I like to be contrarian, Andrew, as you've gotten to know me now over the past few weeks. And whenever there's an opportunity to say something a little unusual, I usually jump at the chance. I do think there's an opportunity to remind everyone that, the U.S. government, every time it changes administration, there is a change in the cabinet. And that means that all the commissioners typically get replaced. And that is a refreshing exercise. You don't get dictatorships in these institutions. You get tours of duty. So it's just nice and pleasant to hear it. I want to jump in firstly with a macro topic of positivity. The FDA is still, by many respects, the gold standard for evaluating new drugs, new devices, keeping a health industry safe. And I want to remind everyone that healthcare is not easy. I can't say that enough times. Healthcare is not easy anywhere. We were on the phone last night interviewing one of the original US operators of healthcare in China, and they've been expanding across China over the last 20 years. And their journey is fascinating, but far from easy. And this is true. This is repeated in every country. Healthcare is not easy anywhere. So the FDA has really developed into a gold standard. What do you love about the FDA still to this day? And what do you love about US healthcare? What really stands out for you as areas of great strength for us?
Well, the answer to that question, Roy, is in some ways a little bit of the story of the trajectory of my professional career. When I started out in medicine, when I graduated from medical school, I basically inherited a paradigm that had been in existence for literally centuries. It was a paradigm that was based on our observation of the manifestations of disease. My big day was when I got my little white coat, short white coat, and my little black bag. And that black bag was my toolkit, basically, a stethoscope so I could listen, and ophthalmoscope so I could see. And it was all about being able to observe manifestations of disease and then try to figure out what to do about them. We got really good at that. We got much better at the tools. CT scans and ultrasounds allowed us to see better and hear better, but the paradigm remained the same. But during my career at MD Anderson, in large part stimulated by the National Cancer Act of 1971, cancer really led not just a revolution in medicine, but what I call a metamorphosis in medicine. We went from macroscopic and microscopic observation of manifestations of disease to the beginning of a molecular understanding of diseases. We began to understand the genetic and molecular and cellular mechanisms that were responsible for and underlying a disease like cancer. And that really created a metamorphosis. We are in a completely new era and a new reality of medicine that is based on true understanding of the mechanisms of disease, which intuitively inform us as to what we should do in order to detect, eliminate, ameliorate those disease processes. So science and technology have driven this revolution. And discovery and development is creating literally what we would have thought of years ago as miraculous interventions. I mean, truly the blind can see. And an example of that is once we understood a mechanism as to how cancer tumors would grow and how they grew, and that they were able to trick the body into making blood vessels, and we understood that mechanism, we immediately intuitively knew that we could stop or slow that growth of that tumor by interrupting its ability to create new blood vessels. And so we learned about angiogenesis, and we intuitively found anti-angiogenesis drugs. And first drug that came along did a great job of doing that. But interestingly enough, its greatest application today as a drug class is for wet macular degeneration of the eye. So it's a completely new era and reality. And all of those opportunities do not come to fruition in the sense that discovery and development does not get delivered to a patient and being able to change their lives or save their lives until it goes through the FDA. And so the FDA is really the hub around that discovery, development, delivery cycle that can accelerate it appropriately and, when appropriate, slow it down so that we don't run off the road, so to speak. So FDA is crucial. It's critical. And it's the key to our ability to bring to the rest of the world what we are enjoying in the United States, which is basically the finest healthcare in the world. If you have cancer, if you have a serious cardiac condition, on, there's no better place in the world to be than in the United States and being a beneficiary of the healthcare that we can provide, that we can talk.
I love hearing you say it because I often feel, Andrew, like I'm one of one in America who dares to say these things. And yet, when you look at the actual data, we are the best healthcare in the world. That doesn't, and when I'm talking about data, I'm talking about treatment, actual health care. I'm not talking about health. I'm not talking about life expectancy. And I'm not talking about New Zealand. This is like my bugaboo of, always comparing the US to New Zealand, which is the strangest thing I can possibly imagine. I'm talking about cancer survival rates, right? I'm talking about innovation in healthcare. I'm talking about the strength of our health systems, the Mayo Clinics of this world. I'm talking about 10-year training programs for physicians that go through fellowships. I was, again, last night with our China operator, good friend. He's not finding clinical physician expertise in China. He doesn't see those academic institutions. There's no comparison. It doesn't mean that they're not interested in finding and building them. They're interested, but they haven't built them yet. And yet here they are in the US, and we're gonna delve into areas for further improvement. But I think this is a big theme that you and I are very much aligned on. We start from a relative, and the emphasis is relatively great place here in the US. And I'll say another thing to you. I find it interesting that the US, because it's so self-critical, is always poised to attack itself, almost like some kind of antibody living within an organism. We are poised to find what's wrong with our health system. And in the process, we develop blind spots for what's actually really working. I'll give you two great examples. One is attacking the ever increasing cost of healthcare in the US. The last 15 years, we actually achieved that, right? US healthcare as a percentage of GDP has remained flat for 15 years, 17.4%. No one talks about it. That is a revolution. In the last 70 years, these last 15 years is revolutionary. And we should be studying that. What actually caused all of that? I'll give you another example, is your example. In the last 20 years, biotherapies, gene therapies, our ability to actually take on cancer has improved exponentially. And this is still the number one killer in the US, the number one killer in most countries. We should be celebrating how we've climbed the ranks of cancer survival, right? Cancer treatment plans that worked. And we don't. We attack and we attack and we attack our own system. And that worries me. That should worry both of us. We need to be objective. So, and any thoughts listening to any of that?
Yeah, I would simply reframe that, if you will, that I understand what you're saying about when it appears that we're criticizing. But in fact, I think what I like to describe is critical thinking.
Well, that sounds,
and by that I mean, I never did an operation at MD Anderson, as complex as that cancer operation was and as well as it may have turned out, thank goodness, that I didn't immediately ask myself, how could I do that better? And I think that was also my mantra when I was in government, and then we're talking specifically about the FDA. It was the gold standard. We celebrated our 100th birthday in 2006, and all of the regulators from mature regulatory countries and agencies from around the world came to Washington, D.C. to celebrate that birthday because we were, in fact, the leader. Now, having said that we were the gold standard, there was still the question of, okay, how can we be even better? And to your point, we've undergone this revolution in the United States we've led the revolution, I should say, by virtue of the fact that we made the commitment, we invested, we had the academic infrastructures, we passed legislation like the National Cancer Act of 1971. We built institutions of excellence in research and in care. So if you have cancer, where else in the world would you want to go than here? And that story keeps playing it out. But to your point, how can we be even better? How can the FDA be the gold standard in the 21st century as it was?
Let's go from gold to platinum. Let's up.
Even better, even better. So if the world is changing around us, if science and technology are driving this incredible progress, how do we keep pace with that? What changes do we need to make? Not to criticize the past, but to build the future.
Exactly.
What do we do?
So let's get into that. I'd love to get into that with you. So a few ideas that you and I have spoken about that really stand out to me. One that I find amazing is this vault that the FDA has. Can you share with the audience what's going on in this vault?
Well, I'll share a little anecdote with you. When I first parachuted in, if you will, precipitously to be the commissioner of the FDA, I hadn't spent any of my career there. So I asked the question, show me how it works. We were building the new campus for the Food and Drug Administration up at White Oak. There was one building that was completed, and it was the Center for Drug Evaluation and Research, or what's known as CEDAR. And so I went up to see the new campus and the first building, and I asked when I was there, so every single drug that's ever approved or submitted for approval will go through this building? And they said, yes. I said, show me what that's like. How's that work? So they brought me down to the sub-basement and opened some door that I remember appeared to be like a vault door in a bank. And going inside, my memory is that it seemed like a room as big as a football field with those filing cabinets that have the cranks on them that you can crank open and walk in. Row after row after row. And when they opened it up, those shelves were jam-packed with drug applications that had been submitted, some of which were approved, some of which were not approved. And I looked at that and I said, my God, do you realize the wealth of knowledge that is sitting in this room? Now, we've moved ahead from those paper applications to now, instead of that all being stored in a physical vault in a basement, it's in the cloud. But think about that for a sec.
Paper analog has not been digitized?
Well, it's digital now. It was not then. And there was some attempt at transferring that data and that information from paper to an electronic format, because one of the questions I ask is, what would happen if there was a fire? So my point is, we've got, since the time I stepped in 2005 to now 2025, we've made phenomenal advances into tools with which we can manage data acquisition, aggregation, analysis. And so we're in a different era where we have that data in digital form. And now the question is, how do we unlock it? How do we utilize the tools that could survey that amazing wealth of information? And recall, I emphasize, it's things that were approved, which may be now in the general domain, but there are also things that were not approved. And medicine, we don't generally spend a lot of time publishing negative results. So there are a lot of experiments, a lot of things that we did that we never told anybody about. But we should think about that.
It's such a good point when you think about it, because our minds are trained to have a forward or present tense bias on most things. And so I'll give you a perfect example. I think of myself hearing the news that AI is going to accelerate clinical research and improve it, process data in ways that we can't even imagine and get interesting outcomes and findings that we wouldn't find if we were just working as humans. But the question should also be asked, what about past studies? Studies that were performed 50 years ago should have their moment in the sun with AI. And we might find that a study that was performed 50 years ago gets a very different result with an AI tool examining the data. And so the vault sounds very interesting to me. And I'll give you another bias that I think you and I spoke about vis-a-vis food, right? Let's get into the subject of food for a second. There's a lot of new science, new understanding for which chemicals to include, which chemicals to exclude, red dye, green dye. And I think as you explained it to me, even in the FDA, it's not like, as large as the institution is, and I think it's 18,000 people today that work at the FDA, it's a large institution, but it's not like they can study everything all the time. And it's not like they're directing everyone to engage in studies all the time. So what ends up happening is certain things exist because they've existed before. So you have a red dye in a food, and that's just the way it's been. And so, the idea that we can do more analyzing is very interesting to me. What are your thoughts?
Well, you're raising both an unbelievably complex issue, but also one that's extraordinarily important and needs a great deal of attention. So let me give you a little bit of a historical perspective, and then I will try to focus on the point.
I'm trying to unpack the cognitive biases that affect even the FDA. Hard question.
Well, when I first arrived at FDA, it's organized in a very vertical structure. We have the Center for Drugs, Center for Biologics, Center for Devices, and there's the Center for Food Safety and Applied Nutrition, CFSAN. And my approach at that point in looking at what we were engaged in and committed to, CFSAN was very much preoccupied with the resources that they had available to, which were really very, very limited on food safety. They were taking very limited resources and applying them to what was the immediate threat, food safety.
What was limited? What was the size of the team, just so I can imagine what you...
I don't remember the exact number in CFSAN, but I will tell you that at that time, you mentioned 18,000. There were only 9,000 people at FDA when I came through the door. That workforce had been shrinking with attrition. There was, average age was 47. There was no one under 30 in the agency. And 30%, 1/3 of the workforce was eligible for or had exceeded retirement age. So it was an agency that was managing an exhausting portfolio with diminishing and limited resources. And CFSAN was one of the agencies or one of the centers that had no additional funding through user fees, which the Center for Drugs did, in fact. So my point is here was a critically important component of FDA that was overly burdened and under-resourced. And my approach at the point to the center director, and I remember the conversation very vividly, I said, I understand the importance of food safety, but we're also called the Center for Food Safety and Applied Nutrition. And the only thing that we're offering is the food label on cans of tomato soup or whatever when you walk into the supermarket. And that food label itself is woefully outdated. And there are things about it that need to be addressed. They literally did not have the capacity at that time to do that. So the first issue for being able to address applied nutrition is the capacity, the resources, the infrastructure to be able to do that, the intellectual capital to be able to do that.
It is, and I'm going to interrupt you because it's just so fascinating that I just want to reaffirm for the audience what we're hearing here in our current times. So in our current times, the message that's being driven all the time is our government is bloated and there's just too much. There's too many resources, there's too many staff, too much money spent, and not enough effectiveness on the other side. And I think we have to try to remember that too much in aggregate doesn't mean too much everywhere. And it's a really complex system of institutions. And you're going to find at any moment in time, and this is irrefutable because this is just basic logic, some systems are going to have too little. As we look at the FAA that, represents that it's understaffed and planes are falling out of the sky all of a sudden, first time in 20 years, you're going to find that some systems have too little. RFK Jr. is on the cusp of being appointed head of the health department. And I don't know that he takes on the food industry without people. And so these things are in conflict with each other. You cannot starve resources in all departments and expect to achieve great ambition. But keep going.
Well, let me expand on that, because I think that's the critical important point I want to actually emphasize. And that is, you need the right people. And of course, you need them in the right numbers, but you need the right people. And this is a critically important time for this issue of nutrition and the role of the FDA. In the past, the FDA's role was limited, and in fact, its major contribution was the food label. But what's happened in this first quarter of the 21st century is we now have, like with medicine, a totally, completely new view of nutrition. We now are understanding nutrition at the molecular level, just the way we're understanding drugs and their effects at the molecular level. So in fact, today, in 2025, single most important biologic response modifier you put in your mouth every day are not the drugs you're taking, but the food you're eating. And food as a drug, in terms of its ability to alter your fundamental genetic, molecular, and cellular mechanisms, is now profoundly important. So we want to amplify and integrate what is being done in CIFSAN around nutrition with what's being done in CEDAR with regard to drugs, what's being done in CBER with regard to biologics, because the science of understanding those mechanisms is now horizontal. It's not vertical. We may be still trapped in vertical structures that we created at a time when we saw diseases in different vertical categories. But from a mechanistic point of view, we're understanding now that there is horizontal integration. I used the example at the very beginning of a drug for cancer that turns out to be the best drug available for patients who are going blind from wet macular degeneration. That's horizontal integration. We need horizontal integration at the FDA, and we need to integrate nutrition into the same science, into the same rigor that we're using to understand drugs.
I don't think it's an accident that with technology, we've created many more channels of communication for different audiences to express themselves. So long-standing assumptions that are dominant and define our focus and our resources and our presumptions are coming into question. There's some great effect that will lead to great outcome, and sometimes to terrible effect and will lead to terrible outcome. But it does feel to me like a time of change where everything is questioned. And one of the healthy questions that we've asked is, why are we so sick? And I know that some people have been asking that question for the past 20 years, and they've just been in isolation. It's been like an echo chamber. But now, in this environment that we're in, enough people are asking the question, why are we sick, that the public has now focused on the question, and they're discovering that the answer is not what they thought it was. It's not because we don't spend enough money on healthcare. We spend more money on healthcare than every country in the world spends in total on itself, bar exception maybe 4 or 5 countries. Healthcare in the US is larger than 95 countries. That's how much we spend on healthcare. This is not a money problem. Now, we can talk about access to care and equality in care, and I'm not saying that all the money is spent correctly, but this is not a money problem. This is an awareness and a focus problem. We are primarily sick because no matter how much healthcare we give people, if they're going to eat horribly and eat poison, right, and eat the wrong ingredients, just like you said, food is the greatest impact on our health, more so than the drugs that we take. We are unhealthy for other reasons as well, right? There is a long list of reasons, but people have to try to appreciate that the patient shows up already sick when they go and visit a doctor, and it's not the healthcare industry's responsibility to manage human behavior or manage the food industry in large. Having said that, the FDA does play a critical role. So it is going to be interesting to see whether what was a small department becomes a very large and very effective, well-led department with a focus on nutrition.
Well, it has to be all of those things, and it has to remain integrated within the FDA. It can't be carved out now as something separate and apart at a time when the science it needs to be integrated. And that leads me to a larger comment of the fact that what you're describing is we have a systems problem, and it requires a systems solution. FDA will be and needs to be a critically important part of that system solution, but there are other parts to it. And let me give you an interesting example of why this is so important and what we could begin to think about differently in the system. So first of all, as far as the role of nutrition, we now know that depending upon what you eat or don't eat will alter or change the microbiome, the bacterial makeup within your gut, which is critically important because depending upon that microbiome depends on how your immune system will or will not respond to a drug to treat your cancer. We see a systems there that is integrated. What about how we are dealing with the larger issue of the system by which we create health? Steve Bird was the former CEO of Safeway, and he had a brilliant vision that he wanted Safeway supermarkets to be a place where you went to get a prescription filled for your health by virtue of the choices you were making when you pulled things off the shelf and put them into your basket. And the idea was, how could we help people make better choices if we had their background information? And I don't want to go too far with this because it really isn't a detailed story, but it's a very elegant one. Safeway or supermarkets, by virtue of the fact you use that little swipe card or put in your number, they know exactly what you're buying and how much of it and when. And they can, over time, begin to get a profile for you and your family. Now, if you match that to your medical record and knew that there was an issue of high blood pressure, and maybe salt restriction was important, or cardiovascular disease, and maybe the amount of fat or saturated fat was important, how could you then utilize those technologies to help people when they went down the supermarket aisle to make a better choice? Maybe a can of soup that had less salt in it than something else.
Such a great.
Here, my simple point to a very large discussion is we need to come together and think about a system solution to what is a systemic problem. You're absolutely correct. We have to deal with food as if we were talking about medicine. There are many aspects to that. We don't even treat food the same at the FDA as we do drugs because they are both regulated by different legislative laws or statutes. They're not the same statute. They're not the same authorities. They're not the same ability for the FDA to manage or control it. And that's a longer discussion, but it's part of some of those reforms that we may need to think about to bring FDA into 21st century as the gold standard as to how to regulate food.
You do, Andrew, highlight the other 50% of the coin, which again, even I'm trying to lead a very healthy, insightful discussion. I completely overlooked it. So it's just so easy to miss these things. We could regulate food like black belt ninjas and zap every bad ingredient we think is out there two things will still remain. One, there'll be plenty of food choices. And two, which is the other side of this coin, which you're highlighting with a Safeway example, we're only going to do as well as we are informed to do, informed about ourselves. And as far as I can tell, there have been many attempts to try to create health wallets, individual health wallets across the country. It hasn't been successful. As I leave my house every day, one thought that occurs to me now every day is everyone, as far as their health is concerned, was born today. From a data management standpoint, no one is carrying, everyone carries ID, everyone carries credit cards, everyone carries a phone. No one is carrying a comprehensive soup to nuts library wallet of their health. All their MRIs, all their x-rays, all their blood tests, all the notes that they receive, all the treatment plans that they've been part of, let alone analysis that is observing all that information. And so we're all basically babies from a data standpoint. We're all newborns. And without that information, our ability to really make good decisions around food is going to continue to be heavily handicapped. So we've got some work to do.
Yeah. But what I think is most important about that is the work that we have to do is capable of being done. And what I'm witnessing is the pace and the rate of change, the pace and the rate at which we're able to make these mid-course corrections or these transformations is now astoundingly efficient if we choose to utilize it. So, Roy, to your point, what we're telling people is we have to create a better future, but not 50 years from now. That future could be within a couple of years. And so
let's focus on that, the couple of years. I think it's fascinating. So let's dive into it. But I interrupted you. Go ahead.
No, it's just simply, I think we fail to realize sometimes that we're in that upper hockey stick swing of an exponential expansion. Just stop for a second and pause and think about the changes that have occurred all around you and in your life in the last 5 years. My point simply is we should be very optimistic about that, about this thing. We should see that it's within our grasp to be able to create the new future that we know is possible because it's beginning to emerge all around us. We just have to organize it and deliver it. But it's not a goal that, it'll take us 50 years to do that. No, what it took 50 years to do before now takes 5 months.
Staying focused on the data for signs of change, very important, because initially those signs will be a little bit hidden. That's the way these things normally work. So you really have to look deeply to find ever-growing blue zones across the United States. We just have to spend the time. I want to focus you on a related question, and it's my last question because I know we have limited time today. Speed of change. You mentioned 2 years, not 20 years. The FDA, if we think about what a layman looks at and likes to criticize, it's usually your cost of development, not necessarily cost of approval, but it's indirectly the same thing. The cost of these studies measured in billions of dollars now. Timeline of development measured in many years, maybe even more than decade, to actually get out there into the marketplace with transformational drugs and devices. You've also spoken about the FDA housed within the larger health department. I know they call it Health and Human Services, but the Human Services part is interesting. Really the health department and the other institutions that fall within that family, that tree, the NHI, CMS, CDC. And I'm not sure that you think the FDA belongs within that family as opposed to being independent. So thinking about all that's happening, AI, supercomputers, new drug discoveries, and thinking about speed and cost, how should the FDA be structured so it can be part of the solution in terms of speed and cost, and not? And I don't want to be too reductive about it, because actually FDA slowing things down is part of its purpose to ensure safety. But how do we ensure that the FDA remains performance orientated? 2 years, not 20 years.
Well, I hope we'd have another opportunity for a podcast that focuses just on that question.
Anytime you want, Andrew.
Because there are multiple components to it. When I was there, I love analogies and metaphors, and the one I used for us at the agency was we should become a racetrack. And the concept of the racetrack is that Formula One cars can go around at 220 miles an hour safely. So we want a regulatory pathway that's akin to a racetrack in that it's free of speed bumps and potholes, but it has very, very rigid guardrails. And we want the traffic that's going around through that racetrack to go as fast as possible. And if that's 200 miles an hour, that's great. We don't want to slow down the process of discovery, development, and delivery. We don't want to slow down the ability to bring that effective therapy for metastatic pancreatic cancer or that treatment for Alzheimer's disease from the laboratory to a patient. We want to accelerate, not slow that. But we do that by looking at smoothing out the speed bumps and the potholes. And we do that by having strong guardrails so that if things begin to go a bit awry, we stop them before problems occur. So you want strong regulation, but you want regulation that's appropriate. Now, I think there are a number of structural and functional changes at the Food and Drug Administration that would facilitate that. You mentioned one that's a very significant structural change that is a pretty heavy lift by any stretch of the imagination, but it's one that every single former commissioner unanimously agrees with. And we've published that in proceedings of the Aspen Institute, where we came together and we all agree that the FDA should be an independent agency. And there's a lot of reasons why that would enhance function, and it aligns very much with what the FDA's sphere of impact is, and we could get into a lot of that information. But when you think about how much of our life and our economy is dependent on the FDA, when you think about all of the relationships that the FDA has that are intimate and integral to its mission with Department of Defense, with trade, with Homeland Security, on and on, it should be an independent agency, not a subunit of the Department of Health and Human Services. But that's a longer discussion. That's a pretty heavy lift, but there are other structural and functional changes that are much closer in grasp and much easier to implement, which could also have significant impact on smoothing that regulatory pathway and accelerating that progress. I think, for example, we ought to recommend and suggest that the FDA bifurcate its staff into what I call program staff and review staff. There was a lot of criticism of the agency that it, quotes unquote, got too close to the industry. Well, whom else would you rather be close to than the people who know the most about whatever that drug or biologic or device is that they're recommending for approval? You need to have a dialogue with developers and sponsors.
This is good. Conflict, not so good. So that's hard to say. Closeness sounds great. Big advocate for closeness. Conflict of interest, not as good. So there's still that area that always needs.
There's the point of bifurcating staff into program versus review. Let me point out to you that the legislative mandate to the Food and Drug Administration says that its mission is to promote and protect. So we can promote by fostering greater dialogue and interaction between the regulator and the industries so that industries get it right. But to your point, you don't want those people who are the program staff who are promoting and facilitating. You may not want them being the individual who is regulating.
Protecting.
You right. Put a firewall between the program staff and the review staff. I can be on the program staff side and helping facilitate as you go through the early stages
Got it.
discovery and development as a startup company so that you get it right. But once you submit that application, I never see it. It's over the side of the firewall to the review staff, who's totally, completely independent. They have not engaged in any interactions with you that might create a potential conflict or bias. They are purely now objective, because
that makes a lot of sense. Clarity in purpose, clarity in mission, clarity in oversight, as opposed to confusion. That seems to make a lot of sense.
Well, it's one,
but it hasn't happened.
Structural and functional changes that we need to be thoughtful and deliberative about. And there are others that I think are extremely important that I would recommend. But my point to you is there ought to be a rational conversation around what structural and functional changes would eliminate speed bumps and potholes, but still maintain safe guardrails. And I think I have a number of them that I would recommend and propose, and I know other thoughtful people do as well.
I'm going to hope that the new administration, at a minimum, listens to this podcast and hopefully take it upon themselves to reach out to you and ask for your help and advice as we try to implement the best changes for the FDA going forward. I want to thank you for your time, Andrew. And I want to leave you with one question. Did you have fun?
You know, I did have fun, but more importantly, I did find this conversation meaningful because I appreciate the light that you're trying to shine on some of these challenges. It means a great deal to me that we started out with the point you made that we should be proud in the United States of the health care that we have created that is benefiting people around the entire world. And need I mention PEPFAR and eliminating AIDS in Africa? That came from us. It is also true that we should be thoughtful and apply some critical thinking as to how well we're delivering that amazing healthcare. And there are significant issues that we need to address with regard to the delivery of healthcare. And I applaud you for being able to create this kind of a venue to shine a light on some of those issues and to promote the kind of conversation that needs to occur so that we do, in fact, meet promise of this metamorphosis. There is no reason why the blind should not see and the lame should not walk. It's within our grasp to do all of that. And I won't even mention regenerative medicine. That could be another podcast. But we have the ability to not only eliminate disease, we can restore health. And that is the promise for the future. And I applaud you and thank you for the effort to shine a light on that.
You're very kind, Andrew. You definitely have understood our purpose and our mission. Thank you again, my friend.
More than welcome.
Take care.